Hmm. Huh.
A 70-year-old woman was admitted to this hospital because of intermittent fever of 11 weeks duration and new onset back and leg pain. The patient had reportedly been in her usual health with diabetes and hypertension until 11 weeks earlier, when subjective fevers and chills developed shortly after she received pneumococcal and tetanus, diphtheria, and pertussis vaccination. Episodic diarrhea began after a course of antibiotics. Examination of stool revealed Campylobacter jejuni. No treatment was given. Diarrhea and fever reportedly resolved. 2 weeks before the presentation, she began to have low back pain that radiated to her left thigh. She reported no associated trauma or injury. The pain gradually increased without improvement after acetaminophen, and she had difficulty in walking. Her family called emergency medical services. On their arrival, she reported pain at 10 on a scale of 0 to 10, with 10 indicating the most severe pain. The blood pressure was 140 by 90, pulse was 76, and respiratory rate was 20 pulse per minute. She was
So
brought
you
to.
stop here.
Yes, sir.
So elderly diabetic lady.
Yes, sir.
Okay. Now she has fever, back pain, radiating to leg.
Leg.
11 weeks. 11 weeks of fever.
Yes, sir. Intermittent fever.
Barabar?
Yes.
Huh. So what do you think is the diagnosis?
The fever and back pain of chronic duration can be TB spine.
Osteomyelitis of the spine could be a possibility.
Correct. So basically our anatomical diagnosis is something is there in the spine which is causing the fever, because that will cause fever, back pain, radiating to leg. Correct. So now
Yes, sir.
what is that thing is the question. ठीक है?
Yes,
Where
sir.
is the lesion? What is the lesion? ये होता है ना न्यूरो में.
Yes,
You
sir.
can do the same in ID also actually.
Hmm.
So you're right. In our country, the first thing we would think of is
TB.
TB. Other things, what Abhishek said is also correct. It can be bacterial osteomyelitis, because in bone infections, even the acute bacteria like staph, pseudomonas, generally you would expect them to cause a acute illness. But in bone infection, they can also present chronic manner. I don't know exactly why, but it happens. I've seen many chronic osteomyelitis due to staph, pseudomonas, E. coli, many things. Huh? So chronic osteomyelitis or spondylodiscitis with some nerve involvement, possible organisms, staph, cons, TB. These are the main differentials right now.
Yes.
Is there anything else you can think of?
So the patient had diarrhea before, like GI symptoms. So possibly salmonella can also cause a osteomyelitis.
हाँ भाई इसमें तो कैम्पिलोबैक्टर आया ना.
Campylobacter.
But you are right. You are absolutely right. Salmonella is another one which can cause chronic bone and joint issues. Salmonella is one. Salmonella spondylodiscitis or Salmonella osteomyelitis can be there. Generally, patient would be much sicker. 11 weeks they would not stay unless there has been some partial treatment in between. तो वो 2 महीना 3 महीना भी फिर चल सकता है on and off सब problem. Otherwise, Salmonella by first second week patient gets very sick.
Yes, sir.
Second week, third week is a week of complications, no? In Salmonella.
Yes, sir.
But possible. Anything else?
Sir, possibility of multiple myeloma, sir. Uh, fever, fever.
So multiple myeloma possible. Why do patients of myeloma get infections?
Because of immunoglobulin loss.
Light change. So light change, loss of light chains in the urine. So B cell, the humoral immunity gets affected.
तो ज्यादा बन रहे हैं ना, तो फिर इम्यूनिटी कैसे कम होएगा?
Sir, but they are monoclonal.
Monoclonal, ineffective antibodies.
Either
Yes,
Kaplan
basically
and
there is a effective hypogammaglobulinemia
yes.
of the useful immunoglobulins. The monoclonal variety fills up all the space. So there is effectively a hypogammaglobulinemia in myeloma. That is why you get repeated infections in myeloma patients. That is the reason for their immune compromise. Of course, then after you diagnose it, what do you give for treatment?
Multiple myeloma. Bortezomib, what is the B cell inhibitors? Plasma cell
What else?
inhibitors and B cell inhibitors. Rituximab. Checkpoint inhibitors. Rituximab. Or plasma. Plasma.
See, mainly it is bortezomib, dexamethasone, and lenalidomide. So all these are immune modulating, immune suppressing. That is why after treatment again they are immune compromised. Okay. Huh?
Yes, sir.
Then, what else? ब्रुसेला, ब्रुसेला ना, साल्मोनेला जहाँ पे भी आएगा वहाँ ब्रुसेला भी आता है.
Yes, sir.
दिस इज अनदर पेयर्ड ऑर्गेनिज्म. जैसे टीबी के साथ हमेशा एनटीएम बोलने का, सीएमवी के साथ हमेशा एबीवी बोलने का, साल्मोनेला जहाँ भी बोला वहाँ पे ब्रुसेला भी बोल सकते हैं.
Okay.
मोस्ट ठीक है.
Yes, sir.
ब्रुसेला ऑस्टियोमाइलाइटिस वर्सेस साल्मोनेला ऑस्टियोमाइलाइटिस
Versus
ब्रुसेला बैक इन्वॉल्वमेंट वर्सेस साल्मोनेला बैक इन्वॉल्वमेंट. इसका एक टेबल भी दिया हुआ है ना, हैरिसन में टेबल दिया हुआ है.
Okay, sir.
तो बहुत बोरिंग पार्ट है. सम इट अफेक्ट्स प्री वर्टेब्रल, अदर अफेक्ट्स पोस्ट वर्टेब्रल, ऐसा कुछ तो है, मेरे को भी याद नहीं है, पढ़ लो.
Yes, sir.
ठीक है. So brucella is another one with musculoskeletal symptoms. Also melioidosis, very rare, but melioidosis भी आता है, especially diabetic में. Chronic melioidosis is like a chronic infection, long standing PUO, fever, ये सब आ सकता है ना उसमें. So melioidosis is another one. ठीक है. So in terms of non-infective pathologies, can we think of anything?
Neoplastic.
Like fever, ankylosing spondylitis, sir. But fever less.
Yeah, correct. So another thing can be, so you said neoplastic, na?
Neoplastic.
Now which neoplasms cause fever?
Hematological.
Bone marrow.
Sorry.
Hodgkin's causes B symptoms, na?
Yes, sir.
So Hodgkin's, NHL, these can cause fever. Leukemias can of course also cause fever, because leukemias can always become lymphomas. Barabar? Huh?
Yes.
Then so in solid malignancies, which ones can cause? These are all hematologic ones. Solid malignancies जो होते हैं उसमें से कौन से कर सकते हैं?
Bone tumors.
RCC, thyroid cancer, because ठीक है, thyroiditis also causes ना fever, ऐसे याद रखना. RCC, thyroid cancer, then any solid cancer which has metastasized to liver can cause fever. बराबर? Any solid cancer which has metastasized to liver can cause fever. So how does this help you? This flow chart, कि which cancers cause fever? Hematologic cancers, then solid cancers, few of them, and then other solid cancers with liver mets. बराबर? How does this help you? So the cancer patient has come with fever. You don't know if it's due to infection or it is due to cancer. So this is where this flowchart helps you कि solid cancer है, no mets, so fever is not due to the cancer.
Okay.
Then that helps to clarify the differential.
Yes, sir.
Right? Then other thing is if it is a solid cancer with mets or it is a hematologic cancer, then patient has come with fever. So you don't know. So then really you don't know. And since you don't know, you have to treat as infection. Because better to give empiric antibiotic in this situation. If you don't give and it's infective, then patient will crash. Barabar?
Yes, sir.
So this is how this helps you. Okay. So the elderly lady hai, she may have some cancer somewhere with bone mets. That's why there is some fever and back pain and radiation and all that. Rare, but possible. Okay. So and you need liver mets for fever, but bone, I'm not so sure. I'll have to read up, but possible. Then what happens to alkaline phosphatase in myeloma?
This will be, so bone involvement is there, so it will be raised.
So due to osteolytic
It will be raised.
हम लोग अपने MCQ एग्जाम भूल गए. Alkaline phosphatase is a marker of bone formation, new bone formation.
So it will be reduced. So
No, it will be normal.
bone form नहीं होगा.
माइलोमा में क्या होता है? There is a pure osteolysis.
Yes. Yes.
There is no formation at all. जब pure osteolysis है ना, तो alkaline phosphatase बढ़ेगा नहीं.
Yes.
बराबर? So always remember that. So some mets cause bone formation as well as bone destruction. तो उनमें alkaline phosphatase बढ़ेगा. माइलोमा में नहीं बढ़ता है. ओके. सो जब प्योर ऑस्टियोक्लास्टिक एक्टिविटी हो रहा है ना, तो फिर नहीं बढ़ता है अल्फास. You need bone formation. Now, what is a disease of the bone which may cause high alkaline phosphatase? Paget's disease. Yes, correct. Paget's disease में alkaline phosphatase काफी ज्यादा होएगा. Then there are some rare diseases which fall in the group osteopetrosis.
Yes, sir.
Marble.
हाँ, तो उसमें ज्यादा bone formation होता है, but the bones are not resorbed adequately.
Yes, sir.
So the bone formation is high, but the bones are brittle.
Yes, sir. Little bone.
बराबर?
Yes, sir.
Now, can you tell me what you know about hypoparathyroidism, pseudo-hypoparathyroidism, and pseudo-hypoparathyroidism? I'm not making this up. ये सच में है reality में. हाँ? हाँ, बोलो.
याद नहीं आ रहा पड़ा.
अरे हाइपोपैराथायरॉयडिज्म तो बोलो यार, वो तो आना चाहिए ना. Pseudo जाने दो.
So T3, T4 levels will be reduced. Parathyroid.
क्या?
Parathyroid.
So hypoparathyroidism can be due to the either the central cause in which the
PTH, it can be primary, it can be secondary. So primary will be because of decrease in the PTH.
अरे primary, secondary, tertiary नहीं पूछ
तो
रहा
hyper
हूँ.
हो गया.
That comes in hyperparathyroidism. I am asking hypo.
destruction of the parathyroid gland.
Parathyroid glands. I didn't know. Increase increase.
See, what does the parathormone do?
Increase the calcium levels in the blood.
From the
Or
blood.
it has hostrolytic activity of the
It
bone.
maintains the calcium level in the blood
Hmm.
by reabsorbing from the bone and by reabsorbing from the kidney
Yes.
whenever it is needed to maintain the calcium level in the blood.
Yes.
Barabar?
Yes.
Now, if there is low parathormone, you will have hypoparathyroidism. Barabar?
Yes, sir.
So what happens in hypoparathyroidism is that parathormone is not working well.
Yes,
So bone resorption जितना होना चाहिए उतना नहीं होएगा, and kidney में से resorption जितना होना चाहिए इतना नहीं होएगा. बराबर? So there will be hypocalcemia and hypercalciuria.
Yes, sir. Yes.
बराबर? हाँ? And because bone resorption नहीं हो रहा है, bones will be thicker and all that. So maybe the bones will be brittle and all. I don't know. पढ़ना पड़ेगा. ठीक है? But that's possible. Some skeletal manifestations are possible. Okay.
Yes.
Then, so ये हो गया hypoparathyroidism. उसमें there will be low calcium in the blood, high calcium in the urine. Huh? Hypocalcemia, hypercalciuria. Okay. Now, what is pseudo hypoparathyroidism? Means it will look like hypoparathyroidism, but it is not actually hypoparathyroidism. इसके लिए उसको नाम pseudo देंगे, बराबर?
Yes.
हाँ?
Yes.
इसलिए अपने को सबको पता है कि सच वाला अमित मोटवानी कैसा है. कोई और नया अमित मोटवानी आ गया who behaves more normal, तो we'll say नहीं ये अमित मोटवानी जैसा दिखता है बट है नहीं, ये pseudo अमित है. बराबर? तो pseudo hypoparathyroidism में क्या होएगा? It will look like hypoparathyroidism, but it will not be hypoparathyroidism. So you will have hypocalcemia, you will have hypercalciuria, but parathormone levels will come normal. बराबर? Understood?
Yes.
So parathormone level, पहली बात तो हम intact PTH करते हैं. There is some mechanism behind it. You can't just do normal PTH level. You have to ask for intact PTH level, नहीं तो कुछ गलत आता है. ठीक है? Now how will that happen? The mechanism is at the level of the renal tubules, I think. So parathormone is trying to act, but there is a receptor level problem. So because of the receptor level problem, it cannot do its function.
Yes.
Barabar. So even though parathormone levels may be normal or maybe even high, I'll have to read up, I've forgotten. But despite the normal or high parathormone levels, hypocalcemia and hypercalciuria will be there. Okay. And what will happen because of hypercalciuria? Nephrolithiasis. Urinary stones formations will be high. Okay.
Yes.
So now, we already spoke that parathormone has something to do with the skeletal system. So either when there is high function or low function, there may be some skeletal abnormalities. Barabar? So in pseudo hypoparathyroidism, parathormone not working well. So it will have some skeletal features. Barabar?
Yes.
So those skeletal features are a form of osteodystrophy ठीक है? हाँ,
Yes, sir.
तो that is Albright's hereditary osteodystrophy, AHO.
Yes.
Albright's hereditary osteodystrophy. Huh? Now, rarely, what happens? You may have the skeletal features of Albright's hereditary osteodystrophy. Huh? But the calcium, all parameters are normal. Barabar. There is no hypocalcemia. There is no hypercalciuria. But the skeletal features of that are there. बराबर. तो ये सिंड्रोम को बोलते हैं स्यूडो हाइपोपैराथायरॉयडिज्म. समझा? सो पेशेंट के स्केलेटल फीचर्स तुमने पहचान लिए बिकॉज समहाउ यू आर ब्लेस्ड, यू नो इट बाय हार्ट. ठीक है? और तुम सोचेंगे कि वाओ, आई हैव डायग्नोज्ड स्यूडो हाइपोपैराथायरॉयडिज्म, बट you will find that the urine levels are all fine. So then that is pseudo hypoparathyroidism. समझ गए?
Yes, sir.
हाँ. So this is little complicated, but ये सब छोटा छोटा चीज they can ask you in viva. उनको मस्ती करने का मन है तो, and exam में भी आ सकते हैं. हाँ?
Yes, sir.
Right? So मैं सबका लिंक भेजूंगा आपको, but I hope you have understood.
Yes, sir. सर पीटीएच भी नॉर्मल रहेगा उसमें, सूडो हाइपोपाइरोसिस.
Everything is normal except for the hereditary features. समझ गए?
Yes, sir.
So hypoparathyroidism is you will have low PTH levels, hypocalcemia, hypercalciuria, nephrolithiasis, skeletal features. Okay, ऐसा एक टेबल बना लो आप चाहिए तो. ठीक है? Pseudo hypoparathyroidism, you will have the skeletal features, you will have the hypocalcemia, you will have the hypercalciuria, but the parathormone levels will be normal. So it's a receptor level problem.
Yes, sir.
I'm not sure, but this is I think familial जो है ना, वो familial hypercalciuria syndrome वो आता है इसमें.
Yes, sir.
Then in pseudo hypoparathyroidism, you will have the skeletal features of pseudo hypoparathyroidism, but parathormone is normal, and even blood calcium and urine calcium is normal. Okay? Albright's hereditary osteodystrophy. ये नाम याद रखो. बाकी मैं भेजता हूँ आपको लिंक्स बाद में.
Yes, sir.
Okay? हाँ. Then we talk about primary, secondary, tertiary hyperparathyroidism that now Amit is very eager to tell us. So बोल.
Primary hyperparathyroidism, there will be a low T3 and T4.
T3 T4 कहाँ से आ रहा है भाई?
High PTH levels. There will be high PTH levels from the parathyroid glands, and leading to hypercalcemia, and that will be the primary, and secondary will be the low. There will be because of low calcium levels. There will be a secondary raise in the PTH levels.
Okay.
Because of low calcium levels in the blood, there will be a secondary release of PTH levels from the parathyroid gland.
Okay.
And tertiary will be in case of renal failure, there is a renal osteodystrophy. So there will be very there will be a very high PTH levels in the blood because of renal failure. So because of very low calcium levels in the blood.
नहीं भाई, see, secondary hyperparathyroidism is what happens in renal failure because the renal tubules are responsible for the last